Good morning, good afternoon, good evening, depending on where you are around the world. Welcome to these new HSCT Junior Clubs. Today, we have the pleasure to have two great speakers, Professor Sourri and Professor Gavriilaki from Thessaloniki, that are going to discuss the case on the management of TMA in the setting of stem cell transplantation. So do not hesitate to send your questions through the chat. We will direct them to our great speaker at the end of the presentations. And we'll start first by Dr. Gavriilaki. If you can share your screen and present us some background of this very interesting topic.
Hello. It is a great pleasure to be with you in this journal club. I'm Eleni Gavriilaki from Thessaloniki, Greece, and we will try to present the case of thrombotic microangiopathy, and also we will be very glad to have an interactive discussion afterwards. I will just share my screen to present to you a couple of slides, basically to set the stage and explain why we're interested in this syndrome, and also what we will expect in the future from HSCT TMA. So current challenges in this field. First, we consider HSCT TMA as an endothelial injury syndrome, and we want to also deepen our knowledge on all these syndromes in the future, and that's why we organize also an endothelial injury workshop, which all of you are also welcome to participate online or on site in Thessaloniki after us in December. So HSCT TMA is the first syndrome that we try to understand the pathophysiology, and when we first looked into the pathophysiology almost 10 years now ago, we understood that it may resemble more a typical HUS, which is a disease of complement activation, which is effectively also treated by complement inhibitors compared to TTP. So we tried to provide evidence. I will not go into details into all the assays, but we all know that it's hard to detect in vitro complement activation. But we tried to provide a functional assay to just say if a serum of our patient is activated or not. And this is a simple assay that we have described as the modified Ham test. And now the Hopkins lab is also describing a new assay that does not even need the cell line, which we hope that we can all use in the future. So by this assay, we found increased complement activation in the serum of some of our patients with HSCT TMA, and that is why we thought that we need to select patients that may benefit from complement inhibitors potentially in the future. And trying to find other markers, we also studied soluble C5b9, which is a rough marker of complement activation. And indeed, soluble C5b9 was increased in HSCT TMA compared to GVHD and other allo-HSCT recipients. And we also found, of course, the underlying endothelial injury as expressed here by thrombomodulin and VCAM that were similar in GVHD and HSCT TMA as expected. And we also were able to correlate soluble C5b9 with E6, which is an easy marker of complement activation calculated by creatinine, LDH, and thrombocyte count. And after complement inhibitor therapy, we also measured soluble C5b9, and we found a decrease after at least 4 doses in the patients that were able to receive these doses. So what is complement after all? This is all this complicated schema, but we need to understand some of the targets that may be potentially targets of future therapies in HSCT TMA. And we do have the MASP target. MASP2 is here a component of the lectin pathway, but we also have the target of terminal complement activation, which is actually C5b9 or MAC, as a target of eculizumab or ravulizumab. But we also have other therapies that are under investigation that target C3. So basically, we have C3, MASP2, and C5b9 as targets of our potential drugs. About markers, there are also some other markers that have been studied in a few patients, but for now we think that focusing on the availability of soluble C5b9 would be important. What about the genetic background? The Jodell group at Cincinnati, Sonata Jodell and Stella Davis and their colleagues have pioneered this field in the pediatric setting, showing that rare variants similar to a typical HUS were evident in children that then develop HSCT TMA. And we also try to develop our own panel and study a large for HSCT TMA patient population of 40 patients with TMA and the same numbers of controls and donors. And we were able to find that variants in this gene predispose potentially patients into HSCT TMA. But to highlight the context of the now and the future, we know that the literature has reported incidence from 5 to 44%. It is interesting in our point of view, however, that experienced centers, both in children and in adults, have an average incidence of 15, 16, 70%. Of course, there are many factors that affect this incidence, as the treatment indication of transplant and the transplant population, but we have to keep in mind that it's not a very rare syndrome. That is why we have established the harmonization diagnostic criteria led by Michelle Sotler and Sumitra Vasu that have tried to unify all the new knowledge into criteria that can be useful into clinical practice, with emphasis, I think, on hypertension, elevated and soluble C5b9, as well as proteinuria, as markers that we may have neglected in the past and may also help us in risk stratification, and also as definitions of multi-organ dysfunction with organs such as the pulmonary sinusitis and even the GI that we may have neglected in the past. And this is our experience from Panicolaou Hospital that we have gathered, showing that intestinal TMA may be another entity with GI bleeding in these patients that predisposes to very, very poor outcomes, as well as neurological dysfunction, which may be a sign of a late diagnosis or a more severe diagnosis of TMA, predisposing to worse outcomes in our adult population. So what about the future? Next generation therapeutics, we already have several molecules with the targets that we mentioned before and studies recruiting, and we're happy to be part of these studies that we hope that can give us an indication of a new drug in HSCT TMA in the future. And by that, I would like to welcome all questions. I think the goal is to have an interactive discussion and also take your comments on our case that will be presented by Dr. Sourri. Thank you.
So thank you very much for this very comprehensive presentation. So I don't know if there is no burning question. Maybe we can move to the case presentation by Professor Sourri. Again, do not hesitate to send your questions to the chat during the presentation, and we'll try to address them and to have an interactive presentation at the end. So please, Professor Sourri, if you can share your screen.
Welcome, and welcome for myself. It's a pleasure to have you all here and an absolute honor to be amongst you today. So during the next few minutes, let me just see, can you see my presentation? Can you see it?
It's perfect.
Good. So during the next few minutes, I will share with you an interesting case of a 34-year-old patient with ALL who underwent HSCT and developed TMA. As a hint, I'm telling you that she also got treated with a complement inhibitor, but the results are to be revealed later. So I'll just begin. This woman was diagnosed in July 2020. She presented at the ER with fatigue and describing a general feeling of being unwell. From her past medical history, all she had was irritable bowel syndrome. Her lab results at the ER came back showing pancytopenia. A bone aspirate was performed, which revealed 80% lymphoblasts, and the flow cytometric analysis of the bone marrow sample characterized the blasts as CD19 and CD22 high, and CD10 relatively low, about 26%. The molecular testing for BCR-ABL was negative, and her karyotypic findings were that of a normal female. So once the diagnosis was made, she started induction following the hypercivad regimen. After 2 cycles in the disease assessment, due to the number of blasts still being relatively high, as in 19 and 20% respectively, the disease was characterized as primary refractory. So after undergoing an additional cycle of chemo with CVAD and asparaginase, with significant reduction of the blast percentage in the bone marrow, she was given a cycle of blinatumomab. In the restaging, the patient had achieved complete remission with a negative MRD and less than 1% blasts in the bone marrow. But at the same time, she developed neurological symptoms such as muscle weakness of the lower extremities, which was attributed to the previous corticosteroids. Furthermore, high glucose was observed, and she was put on anti-diabetic treatment. When the time came, she was given the second cycle of blinatumomab, but unfortunately, she presented with more severe neurological symptoms, such as aphasia, slurred speech, and altered handwriting, all of which constitute what we know as cytokine release syndrome, CRS. So CAT scan, MRI scan, and EEG were performed with no pathological findings, and a lumbar puncture was also performed to rule out CNS involvement. It was also negative. Due to the clinical manifestations of CRS, blinatumomab was actually discontinued. The patient, prior to being admitted to the BMT unit, started methotrexate on a weekly basis, mercaptopurine on a daily basis, and vidazine every 15 days. So she was admitted to her BMT unit in January 2021 in complete remission with a negative MRD. Her conditioning regimen consisted of TBI, cyclophosphamide, and ATG. And as GVHD prophylaxis, she got cyclosporin combined with methotrexate. She didn't have any siblings, so her donor was a voluntary unrelated male, 10 out of 10. Her HSCT score was 3 due to the neuropathy and previous lung infections, which unfortunately led to the lower than desired DLCO. So the allograft was administered successfully, and after engraftment, the patient was discharged. Her post-transplant follow-up commenced in our outpatient clinic of our hospital, and up until 5 months after HCT, she was doing okay. However, at around that time, like late June, early July 2021, she presented with low white blood cell count, and a few days later with a skin rash that proved to be skin GVHD through a biopsy that was performed. 3 months later, in October 2021, in another follow-up appointment where she was febrile and feeling very poorly, she had CMV reactivation. And in December 2021, she actually developed symptoms from the GI tract, where gut GVHD was also confirmed. The final blow, in a way, came a year post-allo HCT, when her lab results revealed low haptoglobin, thrombocytopenia, and elevated LDH. And the blood smear showed a significant percentage of schistocytes, as you will see in the following slides. So just as a reminder, we're talking about a 34-year-old patient with beta ALL who received chemo, achieved remission, was submitted to allo-HCT, developed extensive steroid refractory GVHD. She was under long-term immunosuppression, and now had a clinical manifestation that resembled that of TA-TMA. And depicted here in the image, you can see the schistocytes and the two diagrams that show the decline in hemoglobin and the rise of creatine levels on the left. And at the center of the screen, you can see the fall of her platelet count. All of these kindly provided to us by Dr. Gavriilaki. At this point, we thought it would be a nice approach to add just a couple of questions for educational purposes. So I'll just read the first question, and I'm confident you can all guess the answer with no difficulty. So with respect to TA-TMA, sorry, my face is actually blocking the question, sorry. Which is the most useful biomarker for clinical practice? Is it modified Ham test? Is it soluble C5b9? Is it C3 levels or genetic variants? And I'm not sure how we're doing on time. So shall I just give the answer?
Oh, maybe if people want to answer in the chat, we can give 1 minute. So people
yeah.
you can send your answer in the chat if you want.
How do I turn on my chat?
Chat is open, so people can send question in the chat, but nobody, so far nobody answer.
Okay, shall I give it away? I will, okay.
Maybe later, you can give it away later.
If I click on it now, it will give it away.
Okay.
It will circle it.
They are shy, so just move on.
Okay, they're shy. So the correct answer is B. It's soluble C5b9. And I'll just move on to the next question. Okay, I'll just read it out loud. Are the neurological symptoms a negative predictor of survival in transplanted patients? I think that's pretty easy, and I think we'll all agree that the answer is yes. Okay, so enough with the questions and the testing. I left the best part towards the end, and that's because our patient actually got treated with a complement inhibitor that led to successful treatment and full recovery to the point where she was actually TMA free. Unfortunately, she died of a cause completely unrelated to her hematological condition, and that was an orthopedic surgery. She died of complications, so it wasn't TMA related though. So a few information about the TA-TMA. Stands for transplant-associated thrombotic microangiopathy. It's a very heterogeneous disease, as Dr. Gavriilaki mentioned. It involves endothelial damage, complement dysregulation, and microthrombi formation. It typically occurs early, about 20 up to 100 days post-allo HCT, but it can also manifest later, even a year after allotransplantation. The triggers vary, with the precise incidence being unknown, and they involve GVHD, infections, or even both. Both these settings could be combined and cause be a trigger to a TA-TMA. It's a very severe and life-threatening condition that is associated with substantial morbidity and mortality if not promptly identified and treated. Unfortunately, for all hematologists around the globe, and just to make things a bit more complicated, capillary leak syndrome, TTP, GVHD, and VOD-SOS actually have the same clinical features as TMA. Finally, I would like to share with you the TMA triad, which, as you know, consists of the microangiopathic hemolytic anemia, thrombocytopenia, and organ damage. Acute kidney injury, CNS, or other atypical organ damage mainly involves kidneys and brain. However, we should bear in mind that it can actually affect any organ. And seeing as it's considered one of the most severe complications of allo-HCT, and bearing in mind that it's mostly a clinical observation, we should all stay alert for the benefit of our patients. And with that, I would like to thank you for your attention.
So thank you very much for this very interesting presentation and very atypical. So we finally have an answer in the chat and somebody has the good answer. Dr. Perola, so it was, yes, the SC5B9. So that's great.
Good.
And thank you. And yeah, it was very atypical because it's 1 year after the transplantation, and we used to do this is in the first weeks up to day 100. And you say that this is not very frequent. Is that right? Do you have an idea of the incidence of this late onset TMA?
Yes, actually, we have. I think. Thank you very much for this great point. I think it's something that we need to highlight that our population, more than half of our population with TMA, presents after the first 3 months, the first 100 days, which is the definition of early complications. And we have found TMA at the Papa Nikolaou Hospital even at 8 years after transplant, and this patient was also treated with a complement inhibitor, and actually the TMA had a good outcome in that patient. So we think that is something to highlight, at least for the adult population, that it's a complication that is not only in the early but also as a late effect.
But yeah, and in this case, there was a trigger, in fact, because they see that the patient had late onset. It was acute graft-versus-host disease that the patient developed because it.
The patient had yes, acute and chronic later on.
Yeah, it was yes, acute and after some overlap syndrome, that it was as graft-versus-host disease. So we have a clear trigger for the TMA. Regarding the immunosuppressive drug that it was receiving at that time, because to what so far to my knowledge that also calcineurin inhibitors and so on also can increase the risk. So which immunosuppressive drug did the patient receive at that time?
Cyclosporin.
And did you stop the cyclosporins or in the management? What is your recommendations?
Cyclosporin was discontinued, yes, at that point.
And
yes, I think that's a very good point, that we need to stop the cyclosporin to see who is refractory, who in the patient population that stays with the TMA after the cyclosporin cessation. And these are also included in the eligibility criteria of the clinical trials. So I think this is the first management, the first step is important, but unfortunately is not enough for our patients. So to interrupt you, Professor.
Yeah, so first step, we stop the calcineurin inhibitors, the cyclosporins. We saw if the patient improve. If it improve, it's fine. And if it doesn't improve, yes, we have to discuss with the new treatment. And did you discuss also some plasma exchange before the complement inhibitors or not in those patients?
So in the beginning, before complement inhibitors, we did perform plasma exchange in the patients, but we have changed our protocols since we have our experience with complement inhibitors, and we try not to lose time with plasma exchange unless there is an unavailability of a complement inhibitor or the patient is in very severe situation. But for us, our standard practice, like from 2017 and forward, was to start with a complement inhibitor as early as possible if the patient had documented TMA after the first steps of cyclosporin cessation and also GVT or infection management that need to be, of course, evaluated very early and quickly in these patients.
No, that's great, because sometimes when you have this kind of patient, we discuss with the intensive care unit, because most of the time they move to the intensive care unit and say, yeah, we have to do the plasma exchange first, and only if it fails, we move to the complement inhibitors. And this is great to know that you are. I think we should go very quickly to the complement inhibitors. So this is great to have this data, and that you confirm that the key, this is a complement inhibitors that we must start as fast as possible. And we know that for so far we have the eculizumab, but now there is some new complement inhibitors. And do you think one may be better than the other? Do you have some recommendation regarding that?
Yeah, that's a very a question for the future, I think. First, it's important for us to get an indication of a complement inhibitor. And second, I think we will have to see the clinical data of the studies. There is a rationale that inhibitors that also target complement and coagulation, such as narsoplimab, may be effective in this complex setting of HSCT TMA, but we do not have concrete data to compare complement inhibitors. So for now, we use eculizumab or ravulizumab, or try to enroll patients in clinical trials. I know that narsoplimab is also in compassionate use in some countries, and there are also cases of patients being refractory to one drug and changing to another with success, but these are case reports. So I think these are very, very interesting questions for the future.
Yeah, we don't have any definitive answer so far, and this need to be investigated. So we have some question in the chat from one of us. This is from Dr. Gulderen, that say a beautiful presentation. Thank you very much. And that we will go back regarding the plasma exchange on the complement inhibitor, because as you say, the TMA is between the HUS of the TTP, and maybe the management may be different between these two entities. So the use of complement inhibitors as soon as possible, this is for both of the presentations, or do you think for one of them we should do the plasma exchange? And how do you separate the different entity of TMA?
Yes, of course, first there's the issue of availability of complement inhibitors and if we can get them early. And second, we know that ADAMTS-13 is about 40 to 60%, 60% in this patient. And this excellent question gives us the opportunity to further elaborate on this topic. So although we cannot define the syndrome as TTP, we know that there are also some patients for complement-mediated TMA outside transplant that benefit from plasma exchange. And that is also the rationale that we can use plasma exchange, at least in cases that we do not have complement inhibitors. As a marker, we use soluble C5b9, but the recommendation for plasma exchange, I think even in the future, if we have an indication of complement inhibitor, will be limited for this patient population. But of course, I think the most important message is to try to do something for our patients, because our patients can overcome this life-threatening syndrome and then fight with all the other problems that they have.
Yeah. So yeah, it's always something we need to be effective in our patients and to be able to use all options to improve them. Regarding the risk factors, we have one question from Dr. Evangelidis that asks if cytokine release syndromes that we can see after stem cell transplantation, that is a risk factor for TMA? On other
yes, this patient has this unique entity of CRS after after blinatumomab, and we do not have concrete data on CRS, but we perceive that also as an endothelial injury syndrome. So we are analyzing the genetic factors for our patient to see if there is a predisposition. And we also think that we have to keep in mind that these syndromes may be in the same spectrum. And we have to be, in general, more alert in these patients that are predisposed to endothelial damage. Of course, we understand that GVHD is very common underlying condition in our patients, at least adult patients for HSCT, TMA, and I think in our population, GVHD is predisposing and is there almost in everyone that then develops HSCT, TMA. Maybe this is not exactly the same in the pediatric population, but there are also other predisposing factors in them that may be characterized general as an endothelial injury syndrome.
Yeah, this is a very important point, and it was also nicely highlighted at the end of Dr. Sourri presentation that this is the same spectrum with VOD, TMA, graft-versus-host disease with this endothelial dysfunction, and once a patient have some endothelial disease, of course, it may be at a risk factor to develop another one. I want to go back. I will ask Dr. Sourri, what do you think about that? So we have to stop the calcineurin inhibitors. Patient have graft-versus-host disease, or maybe some patient also develop TMA. They just have the calcineurin inhibitors as prophylaxis. But if you stop the calcineurin inhibitors, what did you do for the patient for the prophylaxis of the treatment of graft-versus-host disease? I don't know if you have an idea, Dr. Sourri. This is a tricky question.
It is a very tricky question. Thank you. Thank you for that. I don't have something on that as an answer. From what I know, from having going over the patient's file, it was pretty, in a way, vague. So once they stopped the calcineurin inhibitors, pretty soon they decided that it was actually TMA, and they started treating her. So in a way, they thought that, you know what, it's not GVHD, so we have to go full on and just attack TMA in a way. So it was a really brief period of time that they started the inhibitor. So I don't know if that covers it.
Yeah.
Yes, I agree, and also we usually also start when we stop cyclosporin. We also start with steroids again, just to help with
Have
all
some-
this symptom going on, unless there is an active infection, of course, that may limit us. I think these are also, as mentioned before, just trying to improve GVHD or infections in some way, and also check for these factors are in parallel with complement inhibitor initiation. And sometimes we have to be more quick than we are used with life-threatening syndrome. And, you know, in this situation, assess the patient. Some of our patients, for example, other patients have developed seizures, and then seizures is an important indicator of neurological dysfunction and immediate treatment of HSCT TMA.
So, Dr. Gulderen, is it possible to restart calcineurin inhibitors after TMA resolves?
Yes, I think if needed, we can do it very cautiously. I don't know if you agree, Professor Malard. What is also interesting in this patient and this whole spectrum that we have not presented is that we have also an experience with the ruxolitinib that in some patients we know causes thrombocytopenia, but in some patients they develop TMA after ruxolitinib treatment. We discontinued ruxolitinib, TMA resolved with or without a complement inhibitor, and then when we tried to restart ruxolitinib, we had thrombocytopenia again. But I think in the future we will have even more novel drugs in our hands, and we will have to get more experience on how we can use it in an algorithm in these patients.
Yeah, I agree with you. In some patients, we have to stop the calcineurin inhibitors, the TMA resolve. And in some of them, we try to give again the calcineurin inhibitors when it was not too severe. Some patients did fine, but in the majority, in fact, there was a TMA again, and we have to stop definitively the calcineurin inhibitors. So we try also to do it. And what we used to do also is to give some steroids, also for the GVHD prophylaxis, but it seems to be less effective than the calcium inhibitors. And in a lot of patients, they develop some severe graft-versus-host disease after. So now we are struggling to have some more effective treatments. For some of them that have some very, very early TMA, we had abatacept based on what was published in the US. So it was not exactly the same. We adapt because it was at day 0, but we try abatacept. And in other patients, also we discussed to give ruxolitinib after also as a prophylaxis when we can't give the calcium inhibitor. So we need, with all the new treatment we can use now for the prophylaxis, to see what we can do when we are in the impossibility to give the calcium inhibitors after a TMA. And so far, I think everybody is trying some approaches, and we need now to have some new algorithm to propose.
Yes, and I think for the future, we will also have to to deal with the long-term effects of TMA. And I know your work about the cardiovascular side effects, and I think this will also be an important component of HSCT TMA survivors in the future. And another challenge is also to define the response criteria of HSCT TMA after treatment, which we are trying to have a consensus with IBMT-SC by IBMTR, and we hope that we will have something to present soon. But also in the long-term effects of the cardiovascular and endothelial injury syndromes, we have seen that TMA is also a negative predictor, and that might be something that we have to take into account for survivors of this entity.
Yeah, and you are completely right that you have to take into account the whole spectrum and also the long-term outcome of the patient after they develop, because sometimes when this is a very early TMA, after we focus on the other complication and we forgot about that, but in fact it was not nothing. So we are arriving to the end of this very great junior clubs. There is no question in the chat. I don't know if you have some final comments, both of you, something you want to the last topic you would like to discuss.
Dr. Sourri, take-home message?
Take-home message, just stay alert. Seeing as all these 4 conditions overlap, I think we should just have that in mind every single time we examine a transplanted patient of ours. And I don't think I would say anything else.
But that's a key point you highlight. Just be aware, think about it.
Yeah. And always check the lab results, always. The lab results never lie. Professor
Gavriilaki, last comment?
I think I would say just stay tuned, because we have a lot to see, a lot of progress in TMA, and I hope that we will have a better future for our patients.
So thank you again for both of you for the very comprehensive presentations, the great discussions. We have some nice feedback for all the participants. So I wish you a nice day, and I hope we'll see all of you very soon in a new IHCH Junior Club. So thank you. Bye-bye. Keep safe.
Thank you. Thank you. Bye-bye.
Thank you. Bye-bye.